Good afternoon, and thank you for joining us today. My name is Gordon Sockett. I'm the Group Content Manager for the Medical Imaging Convention, and I'm pleased to welcome you to this digital event around the science behind EUSOBI's new Dents breast recommendations. Joining us today, we have Ralph Highnam, Chief Science and Innovation Officer for Volpara Health, and Carla Gils, Director at the Dutch Cancer Society. We'd like to make this as interactive as possible, so please do submit your questions via the Q&A at the bottom of the panel, and the panel will answer as many of these as they can after their presentations. So now, to begin, I'm pleased to hand over to Ralph Highnam from Volpara Health.
Cool. Thank you, Gordon, and welcome everyone to today's talk. I'm just going to share my screen and we'll get straight into it. Cool. So, yeah, we're going to talk today about the science behind EUSOBI's new Dents breast recommendations. I'm delighted today to be joined by Professor Carla Gils, who ran the Dents trial, which was a big part of the thinking behind those new recommendations. For myself, then, I'm Chief Scientist and Founder of Volpara Health, and we're the company behind the breast density used in Project Dents. And we're going to go talk in depth about that today. Okay, let's just remind you about the European Society of Breast Imaging guidelines, which they issued just recently. We're not going to go into too much detail on this, but other than that top line, that EUSOBI is now recommending MRI screening in women with extremely dense breasts. So they're recommending that women be told their breast density, and they've been recommended that women in that very top category, the very extremely dense breast ones, then should be offered more than just X-ray, and in fact should be offered MRI every 2 or 4 years. So we're going to break down the talk today into 2 sections. One, I'm going to talk about the breast density used in the Dents trial, and then Carla's going to talk about Dents. And just remember then that sitting behind the EUSOBI guidelines is the amazing results from Carla's work on Project Dents. Okay, let's talk about breast density then. We're going to talk about what breast density is and why it's so hard to judge visually. The first paper really about breast composition or breast patterns being linked to breast cancer risk was done by John Wolfe in 1976 or so. And you can see the picture over here on the left-hand side. And he gave different patterns you can see in the breast, and he claimed that the DY pattern over here was much more likely to develop breast cancer than the N1 pattern over on the left-hand side. Unfortunately, Wolf's work proved to be very hard to repeat, and the whole field fell into kind of some disrepute, really. But then in the background, Professor Norman Boyd and Professor Martin Neff in Toronto automated or semi-automated breast density measurement using something called cumulus, whereby a human comes in and draws around the white bits in an X-ray, like you see over here, and draws around the breast edge and generates what they call an area-based breast density measurement. In essence, then, what Boyd and Neff did was they moved from a very qualitative, subjective scheme to hard quantitative numbers, albeit still with some human interaction in there. And really, their work set the scene for Project Dents, EUSOBI, and so on, and transformed the whole breast cancer screening world in effect by proving breast density is a very significant risk factor for women repeatedly across sites and across trials around the world. And it's got to a point now where obviously EUSOBI is now recommending women be told breast density, and many states in the US are also recommending all women be told breast density. So in many ways, Boyd and Neff really transformed patient care by making radiology a more quantitative science. We'll come back to that as a theme in breast density measurement, that quantitative element. Roll on 2013, and the American College of Radiology come out with a new version of the breast imaging reporting and data system, and in there was a new definition of breast density and breast density measurement and reporting from their viewpoint. This is all from the viewpoint then of a radiologist looking at the image and judging what the breast density or breast composition is. as you can see up there on the screen then, they describe breast composition then as an overall assessment of the volume of attenuating tissues in the breast. And then they give 4 categories out, ranging from the breasts are almost entirely fatty all the way through to the breasts are extremely dense, which lowers the sensitivity of mammography. These are just some examples then from the BioRed Atlas, the 5th edition Atlas. And you can see up here, the A then is what they call extremely or very fatty breast. And then D down here then are extremely dense breasts. And as the BioRed states, in this kind of instance, not only is this woman more likely to have a greater risk of developing cancer in the first place, but also for cancer forms, it's going to be hard to see on this white backdrop. So therefore, as the BioRed states over there, it really significantly lowers the sensitivity of mammography. Now, I mentioned Cumulus, and many people try to automate, fully automate Cumulus, but it's proven to be exceptionally hard to automate it for various reasons. But equally, then there's big challenges with the BioRed's interpretations as well. One is around human interpretation of breast density, and this is an example up here where we would find, and just as a background here, Volpara covers around 35% of all US breast cancer screenings now with our software. So we see a lot of different breast density results, and this is kind of a classic case where many US radiologists would call this a B, arguing that it's scattered fibroglandular densities and that there's lots of fat around. But there's also would be a significant number of radiologists who would also say, actually, we would call this a C because there's quite a lot of dense tissue here and here, for example, and we believe there's some masking risk of this dense tissue here and here. So therefore, we would like to recommend that this woman actually goes on for ultrasound. So very difficult to judge visually and very subjective. And that really came over in the Sprague paper, which was published a couple of years ago. And Sprague then showed a group of radiologists the same set of images and looked at the variation in how they judge breast density. And stunningly, I think to me and probably many other people around the world, the variation then in the radiologists who called a breast dense or not ranged from anywhere from 6 up to 84%. Obviously, then that's a huge variation in what is being recommended to women. And of course, variation, confusion, inconsistency, it does not help with improved screening uptake and so on. So visual assessment then of density, very subjective. There's also evidence then that US radiologists read systematically differently to those from Europe. So everyone, so at this point, right, the world recognizes the importance of breast density for judging risk of developing cancer, but also the risk of missing cancer. But we have this this big problem of how to make these scores more objective and more consistent, so we get consistency in patient care. Second big challenge with visual assessment then of breast density is image processing. Radiologists look at heavily processed images for signs of breast cancer. So if we look down the bottom here, this is the same woman imaged over 7 years on GE, Siemens and Hologic X-ray machines. Each of those machines has different ways of presenting the data. Some are much more contrasty, others are more plain. And obviously, all the way through here, then you can see very hard to judge breast density. You would not be able to tell by looking at these images, for example, that the breast density here is actually decreasing. Things get even more complicated when you look at the tomosynthesis world, which is a 3D form of X-ray, where many people do 3D X-ray, but they then generate what they call synthetic 2D views from those 3D breast X-rays, and again, those synthetic 2Ds are heavily processed. So up here, you've got what they call the raw X-ray data that comes off an X-ray machine. That's quantitative, but not so easy to look at. And then this is the synthetic, very contrasty image generated from that raw X-ray. So Big issue here then that these images really vary how you interpret breast density, and an even bigger issue is the manufacturers can change how these images are viewed, but even site by site as well, you can actually change how you, the radiologist at each site, you can vary if you want higher contrast or lower contrast and so on. So all those variations all add up to making breast density assessment by eye even more difficult. Okay, one solution then which academics and others around the world are looking at is using AI and deep learning to learn an ABCD, but typically those AI algorithms are trained on presentation data sets, which we've seen have got huge issues, all from one particular vendor, one particular X-ray model, one particular set of image processing settings, and then with one set of reads from one particular group of radiologists. So, there's a lot of talk in AI about being biased towards data sets, and all those particulars up there make this an area very, very prone to bias. Perhaps even worse though as well is that AI is often set to match or optimize the matching to those particular group of radiologists. Invariably, as soon as you get into groups, you head towards consensus reads, and that means lots of B's and C's. And so the AI algorithm tends to learn to call everything a B or C to get maximized agreement over the data set. And what that means is typically you'll see, for example, far less D's with the deep learning AI models. This is one confusion matrix, which was in a paper recently. And you can see over here that the deep learning model only called 1% or just over 1% of all the cases a D, compared to the radiologist, which called over 4% Ds. So each of those women that aren't called a D are having their risk of developing cancer significantly undercalled, and their risk of cancer being missed also significantly undercalled. So this is a big problem with deep learning AI. So let's go on then to the Volpara approach, and this has been refined since my PhD at the University of Oxford back in 1992. And our aim with this work has been to generate quantitative, objective, continuous density scoring, which people can rely on and which help drive consistency, and which work on, of course, on any X-ray machine. First up, then, we always consider the breast not just a 2D image. We also always consider the breast is a 3D object, and it should be measured and scored in a 3D fashion. So we use the raw X-ray data, which is quantitative. We make assumptions about the breast tissue, namely that it consists of breast, fatty, and or fibroglandular or dense tissue. And we really go all out to try and derive what we call the volumetric breast density, which is a true physical measurement of the breast, which is the percentage of the breast which is consisting of fibroglandular or dense tissue compared to fat, and that's the ratio shown down there on the bottom right of the screen. We do this then by having the raw X-rays come in. We segment these using a mixture of conventional and deep learning AI to remove, for example, the pectoral muscle. We then work out the X-ray attenuation using the X-ray physics between each pixel and the X-ray source. And from that, we can go from the X-ray attenuation to how thick the amount of dense tissue must have been and the amount of fat tissue must have been between that pixel and the X-ray source. And from that, then we generate what we call a density map over here. So you can see here around the nipple here, there's lots and lots of dense tissue, and that's presented by high thicknesses of dense tissue over here. Now, these are 2D images, but we're generating 3D measurements from these. We always call these pseudo 3D, so we know how much dense tissue there was, but what we don't know is where that dense tissue was between that pixel and the X-ray source. But we do know there was 2 centimeters of dense tissue. Now, if you sum all these up, you get the volume of dense tissue. You know the volume of the breast because you know how thick the breast was when it was compressed. So therefore, you can generate the volumetric breast density. Now, we have over 400 publications now looking at volumetric density, and many of those papers look at it in terms purely in terms of volumetric density, but also we give out a correlate then to the BioRed's 5th edition categories, an A, B, C, D. These were set in based on some of the many papers that have come out correlating Volpara's volumetric density, as you see here, with mammo sensitivity. So this was a paper done by EWBC in Rochester, New York, that I think it was in the AJR in 2016. And as you can see, as you expect, the higher the volumetric density, the less sensitivity, until you get up here in the extremely dense part and you're down to 50–60% probability of cancer being detected. We set the thresholds then based on this paper to give kind of roughly 90, 95, 85, and then down towards 70% down here. And what that means is then between 0 and 3.5% gets called an A, 3.5 to 7.5% a B, and so on down. Then anything over 15.5% volumetric density gets a D, and that's extremely dense breasts. And those are the kind of breasts then which Carla Van Gils and Dents in particular focused on. Obviously, that's where we have the biggest issues in terms of sensitivity and in terms of risk of developing cancer. People always ask, how do we know our density scores are correct? Well, we do a huge amount of validation before we publish any algorithm. And we go through a whole range of testing comparing to X-ray phantoms. We always compare to what we perceive to be ground truth, which is breast MRI measurements. More recently, as you see down the bottom here, we started to correlate as well to some breast CT measurements and so on. You're right the way down to actually comparing to what radiologists believe is the density score as well. So a huge amount of validation sits behind each and every release. And it's not just bar human visualization, which we've seen is incredibly subjective and fundamentally flawed, but via these ground truth measurements. This is just an example then of the Volpara scorecard. So this comes out with a B, this one 6.7%, which is kind of towards the high end of being a B, towards a low C. And just to kind of reiterate one thing here, our job in all of this is generate quantitative measurements. Boyd and Yaf transform patient care by making density quantitative, and that is very much our focus. Our focus is not to replace the radiologist, but to drive consistency in breast density scoring. You'll see down on there on the scorecard as well, there's a Tyrer-Cuzick breast cancer risk score. Volpara is the only commercial breast density score validated and integrated directly into Tyrer-Cuzick 8, and we have all the regulatory clearances around the world. Also then sitting behind those regulatory clearances and a lot of what we do, we're a very science-based company, very keen to hear from researchers around the world. And if you look at the literature, over 400 publications now, 200 peer-reviewed ones, including of course with Carla on Project Dents. And yeah, if you look at the literature, there's a couple of papers there. Vision 2020 by Professor Ng was an excellent overview of medical physics about breast density and how you really should measure it versus ground truth. Then more recently, there was a great paper all at AI, and that featured Volpara, and it was very clear that Volpara was by far and away the most clinically validated density tool out there. And a lot of that validation was done independently, which really come out the strength of the science and the strength of our belief in what we do. So with that, I'm going to turn off my video, turn off my camera, and I'm going to open up the floor to Carla Van Gils. So please do use the Q&A, and we'll come back to that after Carla's presentation.
Okay, thank you very much for the introduction. As Ralph was saying, I'm going to talk to you about an update of the Dents trial, which is about screening with MRI in women with extremely dense breast. This is my disclosure. The Dents trial was specifically set up to look at the value of MRI screening in women with extremely dense breast, and it is actually the first and until now the only randomized controlled clinical trial which uses contrast-enhanced MRI for women with extremely dense breasts, and which is all after a normal digital mammography. I come back to that in a minute. We are performing this trial in the Netherlands with the collaboration of the Dutch screening organizations and 8 hospitals throughout the Netherlands who all use a uniform MRI protocol. We have 3 rounds of MRI. What you may have seen in the literature until now is the most attention was for the first round. I come back to that in a minute. There is some publications on the second round, and we are currently analyzing the data further. The trial of the Dents trial has been described extensively in a publication in Radiology of 2015. So if you want to read back how it was done, you can read it there. I always like to start this presentation with this slide, which is also Dutch data, just from the regular mammography screening program. In the Netherlands, we screen women every other year, and this is all women between the ages of 50 and 75. And this is about some 40,000 examinations in the Netherlands that were all scored with Volpara. And we separated the results according to the Volpara classification, and then looked at the number of breast cancers per 1,000 examinations. And we make a distinction between screen detected cancers, so that are detected at the mammography, and interval cancers that are detected in between the 2 years of the screening examination. Here you can clearly see on the whole that it is indeed true that women with extremely dense breasts have a higher risk of breast cancer, quite a bit higher than women who have almost entirely fatty breasts. But what is more striking is that it is the biggest difference is in the red column, so is in the interval cancers. This means that the women do not only have a higher breast cancer risk, but they particularly have a higher breast cancer risk, or have a higher risk of an interval cancer, which did not have benefit from the screening program. And this is translated in the program sensitivity of the screening, where it is 86% for the women with entirely fatty breast. It goes down to 61% in the Netherlands for the women with the extremely dense breast, which is quite a big difference about which we wanted to do something. And then came in our trial, and this is a flow chart of how we set it up. We randomized a bit more than 40,000 women participating in the Dutch population-based screening program. As I already said, it's biannual mammography between the ages of 50 and 75. We included these women between 2011 and 2015. They all have extremely dense breasts. That's how they were selected automatically with Volpara installed in the mobile and fixed screening units in the Netherlands. And they all had a normal mammography. And then we randomized them in a 1-to-4 fashion, where the smaller group of a bit more than 8,000 women was invited for MRI screening, and a bit more than 32,000 women were not invited for MRI screening, were randomized to the arm who would just undergo their normal screening program. The 8,000 women who were invited did not all want to participate. It's about 59% of the women wanted to participate, so 4,783 women, and 41% declined our invitation or did not answer the invitation. We can come back to that later. So our first publication was in 2019, was on the first round of the Dents trial, or I call it the prevalent round, because it makes it a little different from the situation where you have been screened with MRI more often. And I will show that to you within a few slides. So we actually 4,783 women participated in the MRI, and we found 79 additional breast cancers in this group because they all had a negative mammography, so those were all filtered out. So the extra cancer detection with MRIs was 16.5 per 1,000 examinations, which was quite a lot extra. Normally, in the Dutch mammography screening program, in the women with extremely dense breast, we have a cancer detection of around 6 or 7 per 1,000. So this comes on top of that. There was also a lot referral. Close to 10% of the women needed to be referred for further examination. This is quite high when we compare it to the Dutch mammography program, where it is around 2% or so. So that also comes on top of it, unfortunately. And the positive predictive value of referral was around 17%. There are not many other studies on MRI and dense breasts that are of a reasonable size, and you can see here that you need a reasonable size to be able to estimate the detection well. I put up 2 others in this graph, and I'll lead you through it. This one is a bit older, 2017, from Christiane Kuhl from Germany. Average risk women, like we had in the Dents trial, a little less dense, 60% with density C or D, a bit more than 20% with density D. And this was MRI after a negative mammography or ultrasound. A high detection rate, but in both studies, you should also look at the confidence interval, which is quite wide. Also a comparable referral rate as we had. And then there's another study, which is a bit more recent, from 2020, Comstock, from the United States, also in collaboration with Christiane Kuhl. High density, average risk, and they looked at abbreviated MRI versus breast tomosynthesis, which makes it a little different. Cancer detection rate a little lower, referral rate a little higher than what we saw. This is all prevalent studies, so no second or third or fourth rounds. So, but actually more than in the extra detection rate, we were interested in can we reduce this interval cancer rate that was so high in women with extremely dense breasts? Because finding more cancers does not automatically mean that you're doing any benefit. And we thought that, of course, you would preferably would look at mortality, but that would make the trial even huger, and it need to last a lot longer than it did now. So as an intermediate outcome, we have looked at the interval cancer rate, because this would not be overdiagnosis. These are cancers that are really symptomatic and that cause complaints if not detected. So we wanted to see that the interval cancer rate would come down, because if not, then MRI would not seem very valuable, even though you would detect more breast cancers. And that is indeed what we saw. I'll guide you through this. If you look at the women who did not receive the MRI, who are just in the normal every other year mammography arm, we have an interval cancer rate of 4.98 per 1,000. And it was reassuring for us that this was approximately the same as we found in this earlier study that I showed you on the second slide, where we looked in the screening population. If we look at the women who were invited for MRI screening, I explained to you that there was around 40% that did not want to participate, but we followed them for interval cancers, and they have an interval cancer rate which is really comparable to the control arm, 4.88 per 1,000. But if you look at the women who did participate, the interval cancer rate goes down to 0.83 per 1,000. Because, and you may know that from drug trials, if you do randomization, you should analyze this intention to treat, Well, here we analyzed intention to screen, because all these women were randomized to the screening arm. So therefore, formally, you should take the average of the two and compare that with a 4.98 per thousand. This is still a statistically significant difference, but we know, of course, that the effect is diluted because 40% did not participate. So this is sort of the true effect that we see, both statistically significant, a very large reduction. I mentioned a little bit already the false positives. They were quite high, or higher than we wanted them to be, at least. The false positive rate in the first round of the Dents trial is 78 per thousand. But what I also want to show you, that this is a graph from within the first screening round from our most experienced MRI reader, who was used to MRI screening in women with high breast cancer risk. But these women with average risk and extremely dense breasts are slightly different. So he too showed a steep learning curve with a number of MRI studies in the Dents trials he read. And this is the percentage of breast cancer found after biopsy. And then you see that there's a steep learning curve in that, which is promising for the future, I think. So this was the prevalent or the first screening round, but as I explained to you, we went on with a second and a third round. And what do you expect after such a prevalent screening round? In a prevalent screening round, you actually expect to find a lot, because there may be a lot of tumors present that have never come to light just because of the extremely dense breast. And then you come with this very sensitive MRI, and then you sort of empty the pool of tumors, and you detect them earlier than you used to do with mammography. So you expect to find a lot, but after that should come down, because otherwise you know that there's certainly a lot of overdiagnosis. So it should come down. It can be a little higher than a normal incidence, but you're just detecting the tumors earlier. And it's expected to really come down after you stop with the screening modality. This is a very old slide, actually, that was used when mammography screening was evaluated in the early years. But this still holds also when you apply a new screening technique like MRI. And this is indeed what we saw. This is the second or incident round of MRI of the Dents trial. Of the women who were re-invited after the first round, 81% participated again. So that is quite high and reassuring. There's only one other study who also has more than one round. That is the study by Kuhl et al. That I referred to earlier in Radiology 2017. And you can see that both in her study and in our study. So this is the first round. Cancer detection rate is coming down from 16.5 per thousand to 5.9 per thousand. Also a large decrease in the study by Kuhl. Luckily, we also see a very large decrease in false positives from 78 per thousand to 27 per thousand. Also in Kuhl's study, we see this large decrease in false positives. So that is good to realize, because if you're going to implement MRI in a screening program, actually the most rounds or the most examinations that you will do are incident examinations, because every woman has only one prevalent examination. So this is more representative of what you are going to find in practice. So now the EUSOBI recommended in their guidelines that women with extremely dense breasts should receive MRI screening. And of course, the results are from the Dents trial and other trials are very hopeful. But in all the discussions that I have and talks that I give, I also often hear counter arguments, of course, not surprising. Are we worried about overdiagnosis? So detecting much more tumors than you would actually than would ever have come to light if we didn't screen with MRI. MRI is a costly technique. What about that? Can we afford to do it? And what about the false positives? This is also an often mentioned counter argument. This is a table that was constructed, and I will guide you through. It was constructed after we did a microsimulation modeling study based on the Dents data. It was published last year in the Journal of the National Cancer Institute, and we used miscant simulation modeling for it. So it's based on the Dents data, but it's predicted outcomes. And it was used for cost-effective analysis, but also used to estimate how many breast cancer deaths can we prevent, how many breast cancers will be overdiagnosed. So this is how to read the table. In this column, there's the fictive situation that there would be no screening at all in women who are 50 to 75 years old with extremely dense breast, 1,000 women who would be screened throughout this age period. This is a situation that we actually have in the Netherlands, biannual mammography screening between the ages of 50 and 75. And this is the Dents protocol. So what if you do biannual mammography and MRI? So what you see comparing normal mammography with no screening, you see that you would go from 54 breast cancer deaths per 1,000 women to 43. So it's -11. And with MRI on top of that, you would prevent another 8 breast cancer deaths. But this comes at a cost, is estimated by this model of overdiagnosed breast cancers. That also happens with mammography, as we know. This model estimated that from the situation from no screening, where there obviously is also no overdiagnosis, to biannual mammography, that would give 16 overdiagnosed cases. And adding MRI would give another 5 overdiagnosed cases. So yes, it causes more overdiagnosis, but as you can see, it's relatively less than with mammography. So it seems to be less sensitive to that. If we go from biannual mammography to the Dents protocol, we're going to create more false positives, as I showed you earlier. That's what we see here. So this is a slide that I took directly from this cost effectiveness analysis paper that was published last year. And it's quite a complicated technique, and I'm not going to talk you all through it, but what I wanted to show you is just an idea of additional cost versus quality of life years that you can gain by using MRI. So you just have to look at how far the circles are apart from each other. This is the control arm. So this is mammography every other year with its related costs and its qualities gained. Then there's the Dents protocol. It's there every 2 years, mammography plus MRI. So it costs a lot more, but it also gains a lot of qualities. And what you can do with these models is also model different situations. For example, what if you do less frequent MRI screening? Then you can see, which I think is quite interesting, if you do the MRI every 3 years, you gain almost as much qualities as here, but against much lower costs. And you could even think about doing MRI every 4 years. So that is also perhaps a solution to lowering the amount of diagnosis, and of course also to lower the costs and the false positives. Okay, so another way to think about the costs, and I don't have a separate slide on that because we're still working on it, but is of course to work with abbreviated MRI, which should reduce the scan and the reading time. So I think that's really important for the future. But we also worked on artificial intelligence analysis, where we try to learn the software to dismiss screening MRIs without any lesions visible, so that the radiologist would not have to look at them. And of course, we try to do that without missing any malignancies. So we used all MRI data sets from the first round of the Dents trial for that, approximately 4,500 MRI data set, a little more than 9,000 breasts, 838 with more than one or more lesion, of which 77 were malignant, and the other ones did not have a lesion. And when we set the threshold of this analysis to not missing any malignancies, more than 90% of the MRIs with lesions were indeed triaged for radiological review, so they were not dismissed. But we could dismiss approximately 40% of the lesion-free MRIs, so the radiologist would not have to look at that. We still have to validate this in another data set, and perhaps also in the second round and third round of the Dents trial. But this is quite promising in terms of cost and workload reduction. It was published last year. Another thing we try to do with AI, but also with more classical prediction models, is to see how we could reduce the false positive screening MRIs by predicting who would be true positive and who would be false positive. In the first round, we had 454 women with a positive MRI, of which 79% had cancer. So there were 375 false positives that we would try to bring down. We tried different prediction models based on patient characteristics and MRI findings, or based on MRI findings only, because that would be much more practical than to ask for all sorts of patient characteristics in the screening program. And we used the artificial intelligence model, and they performed quite in the same range without missing any cancers with these models. We could prevent 36 to 46% of the false positive recalls and 13 to 20% of the benign biopsies. Also, this still has to be validated in external populations, but it seems like a promising way to go. In conclusion, from what I just showed you, and also from other studies that have been done, MRI screening in women with dense or extremely dense breasts substantially reduces clinically relevant interval breast cancers. It is cost effective, at least in Dutch terms, and this is very context dependent, of course, for MRI once every 3 or 4 years. But if we can make the MRI a lot cheaper, for example, with abbreviated MRI, it will be more cost effective. I showed you that it has drawbacks. It also has opportunities that can be improved. I see an important role for several of the issues. For example, the false positives, the workload, the costs. Before we implement it, I think we should make sure that we have the quality assurance and the benchmarking as good as we have with the mammography screening programs. And not to forget, there are still results from the Dents trial to follow. We are a little behind also due to COVID, and we had to do some mergings with the cancer registries. But we are also going to estimate the longer term effects on the number of late stage breast cancers. So that is still to follow. I'd like to thank all the financial supports of the Dents trial and all the many people who are involved in setting up and carrying out this trial. And with that, I'd like to give back the floor to Ralph, and then I think together we can take some questions.
Cool. Thank you, Carla. And just before we go into Q&A, let's just reiterate that Project Dents was a 10-year trial, or 10-year plus trial. I think it's been going for actually mostly 12 or 13 years now since we sat down in the Netherlands and talked about the early design of it and some of the IT systems that were in place at the time. So just want to reiterate, Carla, just an amazing project. It's kind of project which you do not see much around the world, that kind of length of trial. You have to be very relentless to get these things through. And as you showed there as well, the results are just so amazingly significant for women with extremely dense breasts. Okay, with that then, we will open the floor for questions, and there are a range of questions. So Carl, I'm going to ask you the first one.
Yeah.
Which so the question basically says, why did you end up going with an automated breast density solution?
Why we were going with an automatic breast density solution? That is because I already had experience with it before we started the trial, but I also had a lot of experience with the Cumulus software that you showed in the beginning, Ralph, which was quite good for research and for predicting risk, but we would never be able to use it in a trial this big. And also it was quite cumbersome to use, so it's sort of semi-automatic. And then I started using automated software, which was Volpara actually for the first time in the trial or in the study that I showed you at the second slide, where we just looked in the screening program of the Netherlands, where we just looked at how many screen detected cancers, how many interval cancers, and it was so well able to distinguish those risks, and of course in a fully objective and reproducible manner. So that seemed the way to go for a trial like that.
Cool, thank you. Carla, there's another question here, which is kind of just, was any attention paid to breast volume in the study?
So not as a breast volume, not the dense volume, but the breast volume. So we did not. So in this study, we just selected on extremely dense breasts, whether they were in large breasts or small breasts. I mean, we do have the information. We know that in general, the women with extremely dense breasts tend to have a bit smaller breasts. But we didn't select on it or anything. No.
Yeah, just a bit, might be interesting as well, Carla, looking at MRI performance on different breast volumes.
Yep.
Imagine there'll be some effects in there.
We can still do it. Yeah.
Another question, I'll answer this one. Hardware requirements for Volpara considering processing raw images. Raw X-ray images are effectively the same size as presentation images, especially in 2D. The hardware computing requirements for Volpara density solution are not is fundamentally a standard PC, albeit we do have a research package as well for researchers to use on their own computers as well. So no special requirements. The processing is complicated, but yeah, not exhaustive. Another question here, Carla, was high density related to any specific quadrant of the breast, and did you include that into the trial?
Yeah, so we haven't looked at that either yet. We know that that the density can be higher in specific quadrants. We just used everything here. That's also what the study was powered on, and you can see that you already need a very large trial to do it in this way. It's certainly something that we could look at in retrospect, but numbers will get quite small if you try to analyze it that way. Yeah.
Yeah, and I think from the Volpara perspective, as we talked about in the talk, we give out a density map, so you are able with the Volpara outputs. We just don't give just an A, B, C, D. We actually kind of give the localized density out. We've done some research looking at localized density, but not a huge amount. But certainly that is an area of big interest in the future for us. There's a question here about validation of Volpara versus radiologists, so I'll take that one. And then there's a question straight after that, Carla, about BioRed's 4th edition to 5th edition. So we'll do those two in order. So yeah, predominantly we go all out to validate versus ground truth, which is the breast MRI, the breast CT results. But we always check versus a group of radiologists to make sure we also match as expected. To them, that kind of work shown, and there's tens or if not 50s now of papers out there comparing Volpara's judgment of A, B, C, D to radiologists around the world. Those papers show anything from kind of sort of decent agreement all the way up to excellent agreement, and it very much depends on where those radiologists are in the world and how those radiologists read density, because each country does seem to vary in how they read density. Some radiologists don't give any Ds, other radiologists give lots of As, and so on. So it really depends on some of those factors. But also then, just kind of give you some ballpark numbers, two expert radiologists will agree around 65% of the time on what a BioRed's density category is or should be. The Volpara results on our kind of internal data set, which ends up going to the regulatory bodies, shows around 80% agreement. But then in clinical use, we see anything really between 85 up to 96, 97% agreement. So it's one of those rare kind of AI cases where the software performs much better at a high level agreement number in clinical practice as compared to benchmarking, because of the whole subjectivity of visual reading, and people like to be seeing a Volpara score, and then when they're shown the score, it's a case of agreeing with it or not agreeing with it. And as we said, almost always they agree with it in clinical practice. So that's that part. And obviously over the years then we correlated strongly. We did a lot of work correlating to BioRed's 4th edition. Then 2013, we changed to judging versus the 5th edition. And certainly for Volpara, we changed our lower threshold in AB. We saw a lot more Bs getting called at that point. But also we changed from using the average left-right score to the maximum left-right breast score. So that's kind of the Volpara part of that then. And Carla, how do you believe that change of BioRed's affects some of the things, I guess, with some of those amazing results we've heard from Dents?
Yeah. So I think in the Dents trial, because it was so long ago, it was an older version of Volpara. I believe it was 1.5, if I say it correctly. And I think in theory, it could be that we have missed women that would now be categorized as D because they have smaller patches of extremely dense breast. I think that could be the consequence of it. I'm not sure whether. So if we think about the other studies that are ongoing, like the one by Christiane Kool or Comstock, I think they used a radiologist classification. And they had C or D, and then they still come to quite comparable results. Of course, there's a confidence interval around them, but there seems to be gain of MRI in those high density breasts, no matter how you score them. I think the big advantage of the way we did it, like automatically, is that you would have the same every time, which is really important, I think.
Yep, cool, thank you. This is let's go from the top of it. How about different sorry, with the suggested reduction in MRI screening intervals to get the cost down, would mammography be continued?
Yeah, that's a good question, and this person paid attention very well to the slide, I think, because so what I showed, the 3 or 4 year interval for the MRI, was actually without mammography. So the models without mammography dominated the models with MRI plus mammography. So this is all modeling, this is all simulation based on the Dents trial, but from that you get the idea that in the future mammography may be left out there or after a first round of mammography. But I'm saying this very carefully because this is simulation and one study only. But I know radiologists who talk about that. Yeah.
Cool. All right, there's another question popped up there. What's the mix of X-ray vendors and I believe
No mix.
It was Hologic, right?
All the same.
Yeah, all the same. And the other question here, I guess Carla, I guess is a joint question perhaps to us, or should women be informed of their breast density before a change in supplemental screening adoption by national screening programs?
Yeah. I think this is the most difficult question of this session. I think there's a lot of discussion about it. I can tell you that in the Netherlands, women are not informed about their breast density yet. And the idea behind that was always that as long as we don't have something good to offer, we don't do that. And there's something to be said in advantage of that. On the other hand, you could inform the women because they sort of have the right to know that their mammography is of much lower value, so that they know that if they feel something or if they have complaints or any other thing, they should, even when they have a negative screening mammography, they should be very aware that they should go and see their doctor. So I'm curious what you would say about it, Ralph.
Well, I think after 50 years of evidence, women should absolutely be told their breast density. I think there's enough evidence now that the counter argument usually is about anxiety and about, well, you can tell them this, but we can't just tell them it without doing something. I think there's enough evidence now around the world to show that you can inform them. You can just it's about being honest, really, and giving these people options, even to go private if they have to get extra screening. And I know that's a hard decision, but I think at this point the evidence is so overwhelming that women should be told breast density. But the other thing, Carla, that I love about Dents is screening programs say, well, we don't have the resources, but the fact is, well, let's start with the top 10% or the top 5%. We don't have to do 50%. Let's start there with what the resources that we have.
Yeah, I agree.
Just there's one last question up here about if it was only Hologic as the X-ray vendor, is that not a limitation of study? I'll answer that a little bit, and Carla, you can jump in, and I think we're probably then up for time. The Volpara has been validated over 400 plus papers. That is a mixture of Hologic, GE, Siemens. So as a density tool, we're highly validated across all X-ray vendors. So that part of the I don't think there's any limitations coming from that angle. But Carla, I don't know if you want to comment on that as well.
Yeah, I totally agree to that. I mean, there's a lot of evidence already for using the Volpara in different systems, and if you relate density in relation to risk, for example, you see the same results over and over again. Yeah, we simply had no choice in the Netherlands. We have a screening program where all the mammography machines are the same. So there was also no other way of doing it. But I don't think it has a huge effect.
Cool. Awesome. With that, I believe we're just about out of time. Carla, thank you very much for an excellent talk and for joining us here.
You're very welcome.
And again, we're seeing Project Dents was an amazing project. It's still ongoing. Look forward to seeing future results, and looking forward to seeing how the guidelines play out as well.
Sure. Thank you.